Well, thank you for the nice introduction. I would like to thank the organizers for this invitation. I would like to thank Professor Shuri Nabil and Dr. Peters Safwat for the invitation. It's a great pleasure to be in Egypt. In 2 years, I have been invited 5 times, which is a great number, but this reflects exactly the hospitality of this country. By the way, I've talked mainly in hundreds of countries. The way that I was welcomed here in Egypt is unique. Therefore, thank you so much for this welcoming. A short background on my professional career: medical studies, under and postgrad in Bologna University in Italy. Currently, I'm an associate professor in food sciences at the University of Modena. And I direct the center, the research center for the study of metabolism, body composition, and lifestyle modification. On European level, as EASO, European Association for the Study of Obesity, I'm an active member in the past 15 years. As a fellow of obesity management, I coordinated, and I'm a member of several EASO working groups for the establishment of guidelines and, position statements. Last but not least, recently I joined the European Society of Endocrinology for the conduction of the EndoCompass project for designing research roadmap for endocrine sciences 2025-2030 and the establishment of European policy-oriented recommendations. In all this, I have no conflict of interest. And this is important in a way that you can say what you think and what you find in terms of research. Today's talk will be of the title Obesity or Obesities, and if it's a clinical demand to be implemented in our clinical practice, starting from the actual definition of obesity. As we know, it's a chronic disease defined by an excessive and abnormal accumulation of body fat, and this is associated with an increase of diseases, disability, and mortality. In 2022, the WHO European Regional Obesity Report has been published, and there are very bad news. 60% of the European population will be affected by overweight or obesity. These are big numbers. I don't think that it's a problem of Europe only. It's a problem also of US and the MENA region. Well, from the clinical point of view, whoever have at least one of these parameters is identified as diagnosed by obesity. And everyone in this room agree on this. However, I will kindly ask you to think for a while about your patient with obesity in your clinical practice, if it's an outpatient, inpatient, or whatever. The question here, do you see your patients like figure number 1, or you see your patients as figure number 2? And the other question here is, do they need different treatments and way of management or not? Skipping a step backward, let us think about other clinical conditions. Type O diabetes, we distinguish between type 1 diabetes, 2, 3, 4, and 5. That they have a common denominator, which is hyperglycemia, right? But they differ in treatment. Just think to treat a patient with type 1 diabetes with metformin. What will happen either? Or to treat a patient with type 2 diabetes immediately with insulin. As you can notice, stratifying or phenotyping people with diabetes, the management differs. The same story with hypertension. We can distinguish between primary hypertension and secondary hypertension, and we have two radical different treatments between the two, despite the fact both patients may have high level of blood pressure. Therefore, do you think this is the case of obesity? Yes or not? In the second place, I will try to simplify the rationale behind why we need phenotypes in people having obesity. Mainly because of three reasons. The first one, international scientific association are always pushing toward the patient-centered approach to have a personalized treatment. Our patients are not numbers. Our patients are individual, and even if they have obesity, they may have different presentation of obesity, and they may need different management for this. Reason number two, we have an advancement in the weight loss treatment in terms of benefits, but also in terms of adverse effect, and I will talk about this within a while. And finally, last but not least, we currently have poor results in obesity treatment. This is a matter of fact. In the long term, people that relapse in obesity are nearly 80 to 90%. For this reason, we are not treating correctly our patient. And perhaps the reason is the lack of the existence of phenotypes. Well, here is the patient-centered approach. Recent guidelines push for that. The advancement of treatments. Now we give our patients certain profile. If you are affected by a certain clinical condition, we can treat you in a certain way rather than another. Therefore, the treatment options are based on the patient clinical profile, and this implies we need personalization. And also an adverse effect. I don't know if you read this news recently, especially with the new drugs, tirzepatide, and many talk about it make patient lose an important amount of muscle, right? I don't want to discuss this issue as well, but we have to take into consideration also this complication. I mean, if I phenotype my patient having obesity with low muscle mass, if this drug, yes or not, I'm not sure, it make him lose much muscle, I will avoid it as well. And here are the poor outcomes that are we having in the treatment of obesity. The question here, something is missing, or we are making something wrong at that point. In the third place, I would like to talk about current achievement in clinical practice, giving an example, which is the sarcopenic obesity. I will try to present in these remaining 10 minutes of my talk a work that took me nearly 10 years, which is sarcopenic obesity. Well, sarcopenic obesity is the combination between the increased body fat and the reduced muscle mass and strength. What do we know about this phenotype? We know that its prevalence is nearly 50% in our clinical practice. Not only, it's much associated with type 2 diabetes. Not only, it is associated also with the risk of other cardiometabolic diseases like hypertension, dyslipidemia, and so on. Not only it's a prevalent condition, people with sarcopenic obesity are much ill and they have a poorer physical performance when compared to people with obesity but without sarcopenia. I mean, two people with the same BMI, one with a sarcopenic obesity and the other without, they have a poorer physical performance. They have a lower resting energy expenditure. This same population. We know that patients with sarcopenic obesity have a reduced resting energy expenditure by nearly 150 calories per day compared to patients without sarcopenia. Also, in terms of physical activity, patients with sarcopenic obesity, when compared to non-sarcopenic obesity, with the same BMI, same weight, they are more sedentary and they perform a lower level of physical activity. Not to forget the poor clinical outcome. These patients of this phenotype, they used to drop out the treatment, or they have more difficulties if they finish the treatment to maintain their weight. Therefore, what I can say here regarding this phenotype, that it's a prevalent condition. One, we found that this phenotype of obesity are much ill with respect to other patients in terms of, let's say, medical complications, depression, impaired quality of life, while compared to people that don't have sarcopenic obesity. They have a decreased resting energy expenditure, a sedentary lifestyle, and a reduced physical fitness. And not to forget, they have poorer clinical outcome. Therefore, my question to the audience, is it necessary to identify this phenotype to improve its clinical management, yes or no?
Yes.
The question is definitely yes. And at that point, what shall I do in order to identify this phenotype? Well, we have simple tools. As you can notice, you don't need the DEXA immediately in your clinical practice. You can use one of these. Those on your left are for the European population, and those on your right are for the Middle East population. You can use a very simple tool like the hand grip, for instance, or the walking test in order to screen people with sarcopenic obesity. What are the new directions in this? I mean, under the umbrella of phenotyping obesity. I've talked about sarcopenic obesity, and this took a work of nearly 10 years of research. What do we need now? We need to go forward in this direction. We've started recently to work on a new phenotype, which is the osteosarcopenic obesity. As you know better than me, that bone and muscles are cousins, if not brother and sister. If I lose muscle, I will lose also bone. We have started to study this new phenotype in a study conducted in Italy on nearly 2,500 patients. And what we found that the prevalence is nearly 15 to 16% of our clinical population. However, we need still many studies. There is no consensus about the diagnostic criteria. The impact on health outcome is unknown. The impact on obesity outcome is unknown. And there is no clear news about this. I need 2 minutes only.
Yeah.
Because I lost that.
10 minutes, please.
Yeah, because
2 minutes, please.
yeah. Therefore, we need to study the new phenotypes. This is one. Not to forget also the normal weight obesity, people that are having normal weight, but they have an excessive fat mass, they have obesity as well, and we need to study in this direction, and other phenotypes. Therefore, how we can conclude? Obesity is an umbrella under which several phenotypes fall as they appear to differ between each other in terms of clinical presentation as well as management. We have today strong results that clearly justify the need of phenotyping obesity and revealed of important clinical implication in terms of management, and I'm talking about sarcopenic obesity, and this should be adopted in clinical setting. Despite these progresses, which has been achieved so far, a long way is still to go, searching for new phenotypes for better clinical management in people living with obesity. In order to conclude, I've announced this morning that in summer, June 2026, my center is organizing a summer school in principle of body composition, metabolism, and exercise. Who is willing to come, he is most welcome. And I hope to see you all in Italy. Thank you so much.